right, let's take a look. Alrighty, I think we're here, right? Are we here? Where are we? Where indeed are we? Let's take a look. Let's take a look. Where are we? Who are we and where are we? What's even going on here? Let's take a look. Let's take a look. How are we doing here? I don't even know. I think we're good. I think we're almost good. Let me just make sure this is all tuned in and ready to go. And then once it is, we will we'll go ahead and start the show. Okay. Am I missing anything? Are we missing anything here? What are we missing? Anything? No, I think we're good. Yeah, I think this is good. Okie dokie. Let me just share this. And once we share this, I think we can get the show on the road. You know what I mean? I think we can. Hoorah, Phil. We already got someone here. Hoorah indeed. All right. Okay. Let me just share this real quick and we will start the show. Thank you for being here. Okay, almost there. There we go. I think that's it. I think we are live and sharing and chatting and doing all the things that appear to be the things and the things. So it's awesome to have you all here and see you all here. Hoorah, Phil. Hoorah. Welcome. I'm really excited for this. This should be fun. So good afternoon, everyone. Good evening, good morning, whoever you are, wherever you are. I am Dr. Patrick Lockwood, and this is UnShrink Me. Technically, I'm just Patrick for this purpose because this is my personal YouTube channel, and I'm not trying to represent any of the professional organizations, my university, etc., that I'm affiliated with. So please don't sue me, them, etc., etc. This is just my personal opinions. So welcome, everyone, and I'm glad you're here. I am here to help, essentially. The whole spirit of the UnShrink Me podcast is to help create, provide the best possible scenario for anyone seeking out mental health support. So the spirit of this podcast, if you are brand new to UnShrink Me, the whole goal here is to help the consumer, the regular people. What exactly is sick? To know what is sick, to know what mental health, mental illness actually is, to protect them from fads and charlatans and egotistical maniacs who think they're gurus and all these things. So my goal with UnShrink Me, the reason I titled it UnShrink Me, is because the whole idea of shrink in its kind of pejorative sense is it's some know-it-all psychologist, psychiatrist who just, they are God's gift to therapy. And, I want people to understand the human nature of therapy, the practical realities of therapy, the research, the science of psychotherapy. And so today's episode is no different than any other episode. We're going to talk a lot about some of the nonsense that people say out there in the real world about psychiatry, psychology, mental health in general, so that you have a realistic understanding of what mental health actually is from a more technical, professional perspective. But number two, so that you're not confused or conflicted or convinced, let's say, that what you need and where you're at and the people offering you services are not necessary. Or maybe they are necessary and you can't see how they're necessary. Or maybe they're unnecessary and someone's selling you something. So I'm trying to walk through all of those problems together in this podcast. So I welcome everyone here. Welcome to the chat. Phil Bradley, thanks for saying hello. Hoorah, Phil. And, let's do this. Let's do this. So today's agenda, we are going to talk about a number of things I found on ye old Twitter, because there's nothing like Twitter for those of you who are out there. Lots of great research, got great academics, therapists, psychologists, but, let me see here. Let me find my little list of fun things to talk about. Okie dokie. Oh, we got Ryan Rogers too. Hello, Ryan. Welcome, welcome. So today we are going to talk about many of the nonsense things happening at the American Psychological Association. Oh, we also have Jonathan here too. It's going to get good. All sorts of shenanigans are going to happen in the chat, which I love. We're going to talk about meds. We're going to talk about Justin Garson. Again, we are going to talk about psychiatry. We're going to talk about being unruly. We're going to talk about so many things here today. So please strap in. Let's have some fun. So first and foremost, before I get to the more dense, critical stuff, I want to start with my colleague on Twitter. His name is Dr. Edward Perrin, Perin. And I'm just going to repost this real quick because I think Ed says really cool stuff from time to time. And I'm going to start with his, what is not therapy discussion. Okay. So Ed posted a graphic or a meme. And I think that this graphic, I'm going to repost it right now so you can all see it if you're on Twitter. At Dr. Lockwood, blah, blah, blah. So Ed said about July 25th, a couple weeks ago, he said, therapy is an awful way to treat a friend. And he posted this interesting meme of talking to a friend versus therapy, which kind of has a Venn diagram of what is therapy and what is not, what are the similarities and what are not therapy. So in the Venn diagram, which I encourage you all to see, if this were a more fancy podcast, you'd be able to see the screen image on the screen, but I'm not that fancy yet. So anyways, therapy is where people help you find your own answers on the right side of the Venn diagram. Or therapy is when you get to focus on yourself. Or therapy is when you use personalized, like to the person, individualized to the person, issues and techniques. A good therapist is non-judgmental and tries to be theoretically informed, etc., etc. Whereas a friend is being supportive and giving advice, whereas a therapist generally doesn't do that. With a friend, there's an expectation of reciprocity, whereas in therapy, there is no expectation of reciprocity. That's good. That's correct. Your friends don't always have time and energy to focus on your needs, right? So there's an imbalance of like what the relationship looks like because it's based upon their needs and their time too. Friends might not be able to be fully honest with you and like vice versa, whereas the therapist should be telling you the truth no matter what. And then relating to a friend is about bonding and having a relationship, whereas relating to a therapist is about having a professional relationship, right? So he said therapy is an awful way to treat a friend, and I could not agree more. If your therapist feels like your friend, you have a bad therapist. Let me say that as clearly and unequivocally as possible. If your therapist feels like your friend, you have a bad therapist because there's a lack of professionalism there. So I'm not super professional, so, maybe I'm not a great therapist, who knows? But like, generally speaking, it's very important that the person you're paying all this money and time to, because you're paying in time and you're paying in money, is not your friend. They are not here to make you feel better. They're not here to form a deep relationship with you that's existential and all this stuff. We are professionals providing a professional service, right? Let's go to the chat because I see a bunch of stuff happening here and I feel like I'm already missing out. He says, go off, King. Ed does, Jonathan says, in spite of his being a psychoanalyst. But because Ed's a psychoanalyst, we can forgive him. You know what I mean? Ryan Rogers says, is Mr. Whiskers over there? You mean this guy over here? Right here? Max? Yeah. So Max is an excellent listener, but he's awfully selfish. So I don't think that he would make the best therapist, to be quite honest with you. So, take it for what it's worth. By the way, this podcast is not sponsored, NOT, not sponsored by Celsius, but it is fueled by Celsius. So absolutely love this. But Max is great. Max is a great companion. He's super cool, super fun. He is a little noisy sometimes, but most of the time he just kind of sleeps. So, Max is great. But yeah, just to go back to what Ed said, Dr. Perrin, Perin, he's a great follow on Twitter if you're interested. Great memes, therapy memes. Solid guy. I would say the problem is a lot of patients really want their therapist to be their friend. Because a lot of people with real mental illnesses, real mental health problems, serious trauma, PTSD, depression, so on and so forth, I would say it's not weird that people who are mentally ill have difficulties with social relationships and feel isolated. So they might try to get their friend needs met with you, in all honesty. And the truth of the matter is I can understand why therapists might temporarily fill that role to some limited degree, but that is not our job. We are professionals paid for a specific service to serve a specific function in the person's life, and it is not a personal function. It's a professional function. We have specific boundaries, we have specific limits, and we are not your friend. We might be friendly in our attitude and orientation and approach and all that stuff, but I'm nobody's friend. That's my patient. That's it. So just wanted to start off with that because I think it's always good to be clear about what is and what is not therapy. Okie dokie. What is next here? All right. Let's talk about Lori Gottlieb real quick. So Lori Gottlieb is a pretty influential New York Times bestselling therapist. If you don't follow her, her handle on Twitter is at Lori Gottlieb, Gottlieb 1. And she put out this thing that I think is interesting. We'll talk about it here for a second. Let me retweet it real quick so we kind of know where I'm coming from. Okay, here we go. So here's what she said. She said this on approximately 7/29, so it's about a week or so ago. So here's the post, basically. That's also, she likes to post graphics and screenshots and stuff. So she said, what happens when you stop living for everyone else's approval and start honoring your own worth? And then she talks about this session she had and all these good outcomes. And the post is about reframing as a clinical skill. And if you don't know this, by the way, just to completely, fully inform everyone of the various types of psychotherapy skills, one of the most popular ones, especially used in cognitive therapy, cognitive behavioral therapy, and related traditions, psychoanalysis, things like that, psychodynamic therapy, ACT, etc., is called reframing, where you take a look at a situation from a different perspective. You take a look at a thought, and then you rephrase it and reframe it so it's different. And so this particular post of hers, I'm not going to get into the details of the patient or the session, but I want to get into the original framing that she used. So Lori said, I'm just going to reread it real quick. She said, what happens when you stop living for everyone else's approval and start honoring your own worth? So that's presented as a dichotomy, which means there are two choices, right? So the way she wrote it, maybe this is not what she intended, because I don't know what she intended because it's just a Twitter post. What she wrote is inaccurate, right? She wrote something wildly unrealistic, which is more on the self-help guru side of things and less on the psychotherapy valid way of talking about human psychology side of things. So let me be clear in what I'm trying to criticize, because I already said what she described at the end of her post is great. She used the therapy skill of reframing to help the patient with her problem, which is great, but it's completely incongruous with the first thing she said, which is complete bullshit, which is you have to stop living for everyone else and you have to start living for yourself. That's such horseshit. And let me explain why in the simplest possible terms. So humans are a social species. We are mammals. Mammals are all social species. We need other people. We need cats like that dude right there, or that little white girl down there, if you can see her underneath the pictures. But, we need other creatures to be satisfied and to be mentally healthy. A large chunk of sanity is having good relationships, right? Is having relationships that regulate you, keep you accountable, keep you engaged, encouraged, alive, all these things. So the idea that you do not need other people's approval, she presented it as a false dichotomy, right? This is what I have a problem with. This is why, the reason I created this podcast is to protect people from guru thinking, right? Guru thinking is bad. Self-help pop psychology garbage keeps people sick and creates an unrealistic expectation for being a person, which makes their mental health worse. So that's why I'm railing against this, just so everyone's clear. So Lori said, even though I liked half of what she said, the other half I can't stand, right? So the first half is garbage. The second half is fine, right? So the first half is pop psychology garbage. The second half is reframing, which is a great therapy skill. So she said, again, once you stop, right? What happens, when you stop living for everyone else's approval and start honoring your own worth? So let's be clear. You can do both. You can care about other people's approval, which you do need to be alive and have functional relationships. And you can focus on what you actually need as a person. You can walk and chew gum. Most people are capable of going, okay, how do I have a relationship with someone that takes care of my needs and honors what they need? That's called reciprocity, where you honor both people's needs. That's normal and healthy and adaptive across most cultures. It's very rare for wild self-sacrifice to be the norm in most cultures. That happens in some cultures. But for the most part, reciprocity is what keeps people sane. So we both have to live for other people because we need relationships, and we have to live for ourselves. We have to balance these two things. It's fucking insane to think that you're going to narcissistically or perfectly focus on you and live your best life or some shit like that, and then magically just be narcissistic and take care of only yourself and think of only your needs, and magically people will just be like, oh, it's great, they're living their best life, even though they're selfish egomaniacs. Jonathan says, MFTs have said since Bowen, since the 80s, 70s, that we need healthy interdependence, not dependence or total independence. Exactly. I wish all these people had just read good old Murray Bowen, my buddy Murray, or, Jay Haley, or whatever it is. It's amazing that, balance is considered unhealthy, or that people present these really, really weird false dichotomies to get clicks or likes or whatever. I don't know. It's crazy. So please do not live for other people and do not live for yourself. Live for both. Life is amazing when you have cool people. Like right now, I have cool people here chatting with me. That makes life better. I'm here doing this for me and for myself, but I'm also here doing this for everyone else. I'm doing it for both because DBT, or however you want to think about it, in the dialectical unity of things, blah, 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 we all need each other. And we need to emphasize what's good for us. And the fascinating thing is, which maybe this is what Lori is trying to say, I don't know, but the fascinating thing is when you take the best possible care of yourself, when you're doing everything you need for your physical health and your mental health, when you're eating the best that you can and sleeping the best that you can and having a meaningful career with meaningful colleagues and relationships and a meaningful romantic life and a meaningful family life, when you're appropriately engaging in everything you need as an individual, there will be some natural balancing process to help you take care of you and take care of other people, and try to do both simultaneously. Now, sometimes it means sacrificing a little bit now for yourself so that you have more for yourself later, etc. But like, it's never this perfect dichotomy of all me or all the other person. That's such horseshit. So please, therapist, psychologist, Insta-fluencers, don't talk like that. That's so dumb. Please don't do that. All right. Let's talk about Justin, shall we? So this individual is becoming a regular on this podcast, even though he's never appeared. Justin Garson, if you hear this, you are welcome to come chat with me live. I will host an interview. We can get a studio, whatever it is. I am not attacking you. I am attacking your ideas. So let's be clear that this person, Justin, we've talked about a few times on the podcast. So please let me repost. Okay. So earlier this week on 8/1, so August 1st, Justin said this. So Justin is a known, self-described like anti-psychiatry advocate. And I have problems with psychiatry, which I have stated clearly and precisely and specifically on this podcast. But I am not anti-psychiatry. Just like I'm not anti-therapy, even though I talk about all the bullshit that happens in therapy, all the fads, all the lack of paying attention to countertransference, all the egotistical narcissists who call themselves therapists. I've talked about all sorts of problems in therapy, the problems with graduate psychology and training and all these things. So I'm not anti-therapy and I'm not anti-psychiatry. However, when people go too far, I have to say something because there's appropriate skepticism and criticism, and then there's like statements that don't actually serve people's interests. They're not useful. And I think this is one of them. So all that preamble aside, here's what he actually said on August 1st. He said, this is the whole art of psychiatry, colon. It takes everything about you society deems offensive, excessive, frightening, unmanageable, and says, in quotes, that's not you. That's your disease. But together we can vanquish it. And he says, out of quotes, anyone who buys into their vision loses part of their soul. So I'm going to try and steelman this. I'm going to try and say this. I'm going to try and say what I think he is trying to say in the most charitable possible way. And you can all criticize me and call me out if I'm doing this any injustice and I'm doing it wrong. Okay? If I'm not being charitable, you tell me if I'm doing it wrong and you call me out right away. So if I'm understanding Justin correctly, what he's saying is, just to read it again, psychiatry does this trick to dehumanize you. This is what he's saying, in my opinion. So psychiatry dehumanizes you by taking everything about you that's offensive, excessive, frightening, unmanageable, and says, that's not you, that's your disease. And together we can vanquish it. So let me try to give the most charitable interpretation of that. So what I believe the charitable view of that is that sometimes some psychiatrists, some psychologists, couples therapists, whatever it is, will take a look at a person with a known mental illness that even the blindest of people could see is a mental illness and go, you know what? You're just sick. And because you're just sick and society doesn't like your personality attributes or the way your illness contributes to your interpersonal behavior that people find off-putting, let's just medicate away the extreme parts of yourself. And that is wrong, by the way. The idea of medicating away extreme personality differences is cruel. People with diagnosable borderline personality disorder, narcissistic personality disorder, antisocial personality disorder, if you were to be super cruel and go all Joseph Mengele, Nazi doctor, on them, you could absolutely tame. If you were going to be disgusting and evil as a psychiatrist, you could tame very, very sick people with personality disorders. And you would do it very simply by putting them on serious mood stabilizers. like lithium or Depakote, or you would give them such intense shock therapy that they stay zombies, right? And so if you were to be disgusting as a professional, you would try to medicate away and numb and shut people up with drugs. And unfortunately, I believe that happens. I believe that happens sometimes. I can't say how frequently because there's not really good, reliable data that tells us how frequently that absurd, disgusting, unethical, illegal behavior happens. Because there are no FDA-approved meds for narcissistic personality disorder or borderline personality disorder or antisocial personality disorder. So if you were going to be truly evil as a prescriber, you could just sedate them to the point that they are zombies, destroy their kidneys and liver with lithium, etc. And if you did that, you would take a person with a very serious illness like narcissistic personality disorder or borderline personality disorder, or even very severe bipolar with psychotic features, and you could make them zombies that are super compliant and mindless. But you would basically take a functional person whose personality traits are so severe that they're impairing and life-threatening in many cases, by the way, because severe suicidal behavior in narcissism and borderline organized persons is really dangerous. We don't want people to die. I don't want people to die. Call me a crazy person for that, opinion, but I don't want people to die. And so I'd like them to get the help they need. I don't want anyone to die by suicide. I think it's a tragedy when it happens. Even if it's an understandable tragedy, it's still a tragedy. And so I don't want it to happen. And so these people that are very high risk for suicide, for instance, like folks with untreated schizophrenia who have a history of self-aggression, or folks with bipolar disorder on the upswing from depression, or serious personality disorders or eating disorders and things like that, or serious substance use disorders, I'm terrified that they might die. And I like my license. And I like people not dying and call me crazy for thinking that. And so there's the absurd, extreme evil version, which is medicate them until they are zombies. And that would solve this problem. And that would be exactly what Justin is talking about to some degree. And I hope that's fair, because I do believe people are over-medicated. I believe many psychiatrists and physicians just want to shut people up. And I think that's disgusting, because that's not humane, and that's not what psychiatry was created for. And I get it. Sometimes people are literally out of their mind. And so, Justin, if you can find someone who's floridly psychotic and find a non-medication way to handle that floridly psychotic person, let me know what it is. I'd love to know what it is. So here's what I can't stand about this post. So I tried to talk about it and steelman it in a reasonable way. You tell me if I did that. Now let me tell you what I think about this. So the idea that psychiatrists are just walking around treating people with serious personality disorders where it's literally life impairing, or serious substance use disorders where they will literally overdose and die if not treated, or serious psychosis, or serious bipolar 1, or even serious PTSD. How many cops and military service people have to die by suicide and alcohol because their trauma is out of control? Right? I think it's disgusting to believe that psychiatrists and psychologists and other therapists are just trying to tell people to shut up and not be themselves. I don't know anyone in my profession. I know tons of incompetent clinicians, or people who are below average, or people who are average. I know tons of people like that because LA is just full of therapists. So you're going to meet a lot of people. But I don't know anyone who's like, you shouldn't be yourself. In 15 years in this industry, I have yet to meet a psychiatrist, psychologist, or therapist, or other professor colleague of mine who's like, you should not be yourself. I haven't met that person. And the moment I meet that person, I will absolutely tell you, and I will eat my hat here on the podcast. But until that day, I don't know what you're talking about, Justin. I don't know psychiatrists who look at people with borderline personality disorder, for instance, or narcissistic personality disorder and go, you know what? You are broken and you are wrong. What reasonable psychiatrists do is they go, okay, you have these really severe symptoms. that are impairing your life. How can we work together to manage these symptoms better? Which is not evil. A good psychologist, a good therapist, a good couples therapist, a good family therapist is having a collaborative partnership. We are not in charge as medical professionals. We are collaborators. Shitty gurus are in charge. They tell you what to do or else. And there's a lot of shitty gurus who have licenses and degrees, unfortunately. But good clinicians, ethical clinicians who care about their ethics code, are collaborators. And so it's frankly confusing as shit every time I see one of these posts. Forgive my French, but like, I don't get it. I just don't get it. I don't meet these people. Maybe Justin had one of these psychiatrists and it was truly a narcissistic, evil person who was his psychiatrist. It's entirely possible. I don't know because I don't know Justin or his life. I don't know what the truth is. I wish I could. I wish I could understand. That's why, Justin, if you ever hear this, if you ever care enough to come talk to me, I will talk to you and I will treat you with the utmost respect. I won't be mean. I might curse, but not in your direction. I might have an outsized reaction because I'm prone to them in a non-clinical setting just for fun here to be absurd, right? That's the whole point of this podcast, is to be absurd. But like, I don't get it. I don't see it in real life. So if you want to talk about it, Justin, I am so on board. Let's talk it out. Let's talk about the good vision of therapy and psychiatry and the bad vision of it. Let's talk ethical and unethical. Let's talk greed and shame and disgusting evil behavior. And let's talk about the good people, like many of my colleagues here chatting, who are just trying to help, who are not evil narcissists who are telling you what to do because we know so much and we're so smart and so special. That's not most clinicians, just so everybody knows. Ryan asked a great question, which I don't have a good answer for, but I'm going to try. So Ryan said, do you view anti-psychiatry as part of a bigger political project? He said it seems to have moved from far left to far right. I don't know if it's part of a political project. I'm not sure. I would say that there's a political element in many of these movements. I think like on Twitter, for instance, it's really hard to know with any certainty who is there for what reason. Like Justin could just be a bot. I don't even know if he's a real person. I mean, like, and I don't know because I just don't know. I haven't taken the time to actually like stalk him or something like that because I don't stalk people because I have a busy life. I'm here to just like have fun and like move on and do good work. But like, is it political? I don't know. Maybe. I just think that people pick on psychiatry and psychology and mental health because it's a convenient scapegoat for bad behavior, right? I think there are people who justify their political beliefs with mental health verbiage. I think there are people who are very, very unwell, who are obsessed with politics, people who have been traumatized and things like that. I really don't know if it's part of a political project. I can't tell. I'm not really that involved online. I just kind of like find posts here and there and like try to talk about them. So I don't know. I wonder if there's like a paper, for instance. What would be a cool research study if you want to, Ryan, if you want to go get your PhD somewhere, I recommend it. Go do research on this topic. Join one of the universities that's already researching this because many authors are actually researching this. So, excuse me, are there people who are using anti-psychiatry talking points as part of their political agenda? Probably. Is it part of the movement? Is it endemic or important to the movement? I doubt it. I think there are much bigger fish to fry. I think that we are such a tiny subset of the medical world, of the broader social world, that people don't really give a shit about us unless we do something egregious, essentially. So I don't know. What do you think? You know? So just to summarize, in case you walked in late on this conversation, Justin Garson, Garson, is a self-described anti-psychiatry advocate, and he wants to help people not be stigmatized. So I'm trying to give the best, most charitable interpretation. He's trying to help patients no longer be stigmatized by the profession, which I have a lot of respect for. And I think that's great. The problem is many of the things that he says go so far out into some left or right field that I don't even know where he's basing it on. He may have this convenient sample of life where he was abused or misused or treated poorly by the profession. And that sucks if that's true. Most people don't act that way. Most people are not trying to make you no longer a person. If your personality traits are so severe, they're at the 80th or 90th percentile. If you're at the 90th percentile of trait agreeableness, and if you're at the 10th percentile of trait agreeableness, your life is going to be difficult. Those of us who are super disagreeable do not have a bunch of fans and friends. People have a hard time having a relationship with me in many ways, personally, because I'm always on the why do you think that side of the spectrum. I'm not built to be super fun and gregarious as a person. And so I don't want people stigmatizing me and trying to change me. So I relate to what he's saying. At the same time, I know it's impairing my life because I'm not normal. And the people who are not statistically normal are going to have a more difficult life. That's common sense. So the question is there some way to operate with more metacognition and more self-agency and more self-reflection so that you can go out there and have a better life even if you're built differently? As opposed to cutting to manage your intense psychological pain and your lack of a self-concept, which is often the case in borderline personality disorder, can you find more adaptive ways of living? That's not evil. That's not Mengele, for instance. Ryan asked a follow-up question. Do you think there are people who work in acute care, like Rehabistan, my word, who deal with very difficult patients who just want to calm them down and shut them up? And some patients, for instance, in mania, may view this as an attack on their true self. Absolutely. I completely agree. 100%. And the truth is, when you have very severe illnesses, your quote-unquote true self involves your illness. But that's not your whole self-concept. Your whole self-concept are not your narcissistic personality traits. It might be, in some cases or situations, a larger chunk of how you show up. But it's not you. You are a complicated creature. You have many roles or subsections of your identity, many of which are socially negotiated, like how you show up as a man, how you show up in a romantic relationship, how you show up in your career. All these things are not black and white. So a real person who has a fully integrated self-concept, to use a technical phrase, isn't just their illness. That's a terrible way to look at a person. And for the therapists and clinicians and psychiatrists who see people as only their illness, shame on you. That doesn't humanize people. That dehumanizes people. And that's against our ethics code. That's not how we function. Some people's illnesses are so severe in an acute, time-limited setting that that's the most important thing to focus on in that acute, time-limited setting. But once you're out of the acute phase of the illness, let's make sure we treat the whole person and help the whole person have an integrated, adaptive life across time and space. So I don't think that's unreasonable. However, I see this stuff and I'm just like, what? Where, Justin, do you meet these people? I want to meet these evil psychiatrists who just think they're God's gift to life and they tell you what to do and tell you to shut up. Holy cow. All right, we're going to move on. But Justin, if you hear it, let's come chat. Let's do it. Let's do the deal. Let's do it. Let's do another Justin, because why not? This is a good one. This should be kind of fun. Okay. So 5 days ago, Justin Garson at Justin, Justin _Garson, put out this tweet, which I think I kind of agree with to some degree. So he said, one of the weirdest generational shifts I've witnessed, colon. We used to avoid mental illness diagnoses like the plague. Now, people seek them, even celebrate them. I've heard people rattle off their diagnoses the way people once boasted of fishing trophies. What happened? It's a great question. What did happen? What has happened that has made people overly care about their diagnosis, right? This happens a lot, by the way, in many of the neurodevelopmental disorders, because there's so many great, political and social movements about this, like ADHD, autism spectrum in particular. But this is not new, right? A lot of people in recovery from alcoholism, if you want to call it that, have called themselves alcoholics and addicts for a long time. And so it's not a weird thing. However, it has become massively normalized to talk about your illnesses, your diagnoses openly, which is interesting. Why is that? So there's two variables I can think of. If you all think of other reasons, let me know. So first and foremost, I think one of the big factors is because of the proliferation of social media. There's just so many different platforms where people can get clicks and likes talking about their illness, right? There have been so many fads on TikTok, for instance, where people literally, not metaphorically, will try to showcase symptoms of their mental illness. Like there once upon a time was a very strange multiple personality fad where people try to show their multiple personalities on TikTok. Very weird. Hey, let's be nice. Let's be friends, huh? Let's be friends. Let's be friends. Let's not attack each other. Excuse me. I would say the social media piece is so weird because on the one hand, role modeling how you're managing and overcoming your illness might be a good thing. However, just showcasing your illness, like there were all these fads on TikTok and on YouTube and Instagram, I think that's probably a big reason why a lot of people are openly talking about it. Also, I think there are so many forums and chat rooms and things like that where I would say people talk a lot about their illness. There's lots of online support groups and things like that. It's weird. It's weird. Let's see what she's up to. So Max is on top there, and Willow is the white and gray one. Oh, what are you doing? She's just sitting there. What's she just doing? Anyways, so it's weird. It's totally weird because when I was a kid, no internet, whatever, people didn't talk about their illnesses openly, like Justin said. But I think between the social media piece and also I think there's a lot of people who are trying to normalize, just show publicly what they're struggling with. And I can see a benefit to that, so we destigmatize things. However, any overcorrection is going to have consequences, right? And so once you completely destigmatize something and everything is out in the open, what's the consequence of that? And I think the consequence of openly talking about mental illness, especially frequently and pervasively, is it makes it seem like a bigger part of your life than maybe it needs to. Because I think there are many people with diagnoses like major depression, PTSD, bipolar, where their illness is important. Their diagnosis is important because it's something they have to contend with. And if you talk about it very frequently, then it sends the social signal that this is maybe more important than even you're meaning to make it seem. Or maybe it's a large chunk of your life when in reality it's not the biggest chunk of your life. And so you're sending an inaccurate picture to the world, which I think is a bad thing. I think you should tell the truth, for instance. Because most people's mental illness is not destroying their life all day, every day. Only in the most severe cases of mental illness do you see symptoms that are so severe and pervasive and impairing that their lives are destroyed all day, every day. That's statistically rare. That's less than 10% of people with a diagnosable mental illness, right? That's not everybody. There's the movie stereotype version of mental illness where the person's having severe psychotic symptoms and they're out of control and they can't get grounded in reality ever unless they're on meds. Like that's a small subset of people with a diagnosable mental illness. A lot of people with PTSD or autism spectrum conditions or ADHD or major depressive disorder or panic disorder or personality disorders live perfectly functional lives with some distress, with some impairment, but they're out there going to work, going to the gym, marrying people, having families, having relationships, having friends, trying to do their best. People with serious drug problems are out there living their lives, right? So I think the idea of destigmatizing and making it known is great. When it goes too far, it either makes illness a bigger deal than it needs to be for that person, or it normalizes it to the degree that people think it's more prevalent than it actually is. And it's just not. It's just not, right? Like most real diagnosable illnesses are rare, less than 5% of the population for each particular illness, right? So like MDD is 6 to 7% of the population, PTSD 3 to 4, personality disorders, depending upon which ones, 4 to 5, 5 to 6, with a lot of overlap in these diagnoses. So it's not like we have 100% of the population. If you add them all up together, it's like there's a lot of overlap. A lot of people with narcissistic personality disorder have an alcohol use disorder, cocaine use disorder. A lot of people with BPD have major depressive traits or PTSD. So there's a lot of overlap. And so the thing is, when we make it such a big deal, it seems like it's normal and it's everywhere at all times, and it needs to be talked about all the time. But it actually doesn't, I think. I think most people with mental illnesses don't need to talk about it all the time. Maybe you do to feel normal. Is that useful for you? Is it adaptive? Maybe. But what's the social signal it's sending? And is that useful for you and broader society? I don't know. I think it's a case-by-case thing. But I think between social media and the anti-stigma movement, which I'm all on the anti-stigma movement, I don't know. It's weird. So who knows? You tell me what you think. What caused people to talk about their diagnoses all the time? Word to the wise. Steroids, anabolic steroids, terrible for your health, for what it's worth. So the idea that you can just do a bunch of steroids, get jacked, and it's not going to be bad for your health, your mental health, don't do it. I think it's terrible for you. I mean, talk to a physician. Ask them about the risks of steroids, like heart disease, sudden death, psychosis, rage, all these things. And I think our final post for today is going to be another Justin. Or should it be Justin? Oh, no. Let's not do Justin. We'll save that Justin for later. Let's talk about something real quick, and then we'll get to a longer one. Real quick, I don't know this person at all. Chris Canada, I think. Cannida. Okay. So Chris said on July 18th, a while ago, rather than tell me what to do or say, they encouraged me to ask myself why I was saying or doing anything. If I couldn't tie it directly to helping the patient, then I learned to say and do nothing. So let me explain a little bit more. A lot of times in therapy, when you're having good therapy, there's an urge, there's an instinct that some therapists have to tell you what to do or say. And as someone who mentors and teaches and supervises therapists, here's what I'll tell you. A lot of what I help my future clinicians learn is how to not do or say things, but to understand why they want to interact with the patient in the way they do. Because what I'm trying to role model is self-awareness and introspection and metacognition. And I think that once we understand as clinicians why we want to say the things we want to say to our patients, what's motivating us, aka countertransference, aka bias, aka culture, or our personal beliefs, our values, right? Once the therapist is aware of why they're saying what they're saying to the patient, and they're increasing their metacognition, they're strengthening that muscle internally, then they can help the patient do that. One of the most helpful things, according to the literature, literally, is teaching patients to strengthen their metacognition. And so a therapist that has shitty metacognition is going to be a shitty therapist. It's that simple. So good clinicians, this is for all the consumers of therapy and psychiatry out there. I want you to hear this super clearly because this is not complicated, but it might seem complicated. But I promise you, it's not complicated. Good therapists help you understand relatively neutrally. Good therapists help you understand relatively neutrally why you're saying and doing the things that you're doing. They're trying to help you increase metacognition because the more aware you are of your process, your patterns, your behavior chains, whatever concept, doesn't matter, it's all the same. The more you're aware of what's motivating you, prompting you to say and do the things the way you do them and the patterns that you do them, then the more you can have agency and control over them. The therapist is not going to teach you to have control over them. A therapist is going to help you have awareness over these patterns and then collaborate with you and ask you what you feel like trying to have more agency over this process you are becoming aware of. And so a good therapist is not going to impose their worldview on you. A good therapist is not going to impose their values on you. A good therapist is not going to impose their solutions on you. A good therapist is going to discuss a menu of options. Once you are aware of a thought process, a behavior pattern that is not adaptive for you, in your words as the patient, in your opinion, not us gaslighting you into thinking the pattern is bad, but once you acknowledge the pattern is bad, once you believe the pattern is bad, not useful for you, we will collaborate with you as equals. I am the professional, you are the patient. We have an equal role in this change process as collaborators. So we are never telling you what to do. We're going to help you understand by asking open-ended questions and being curious and highlighting discrepancies and talking about the there that is actually there. Not some fantastical bullshit that doesn't help you. We're going to talk about the real thing, your real beliefs, your real transference reactions, my countertransference reactions, what it might mean, what it might, M-I-G-H-T, what it could possibly mean, not what it does mean. I'm not some super genius AI that knows exactly what it means. I have a hypothesis about what's happening. As a scientifically minded practitioner, as a professor, I don't know shit. I have a hypothesis. Let's explore it together. If you disagree, if you have a better explanation, let's go with that. Because good therapy is collaborative. Good therapy is empiricism, in my opinion. We're going to figure things out together. I am not so smart. I am not so healed, obviously. I'm not so insightful or perceptive that I know everything. And you shall do and think what I believe. That's guru nonsense. You are a person as a patient. You have autonomy and agency. So your job as the patient is to tell me the truth about what you think. My job is to tell you what I think, and we will talk about it. We will explore together. We will collaborate. And that's what good therapy should look and feel like, no matter what the interventions, if it's motivational interviewing or ACT or CBT or DBT or psychoanalytic therapy or psychodynamic therapy or IPT or IPSRT or whatever, in couples therapy or family therapy. I will offer ideas and perspectives, and we will talk about them, and we will collaborate. And that's what works. And the moment your therapist knows everything and tries to interpret things for you and says, this is the only interpretation, think of it this way and this way only, you have yourself a guru and not a therapist. You don't have a professional, you have a preacher. And that's not what you're paying for, just so we're all clear. Jonathan Cogbert says, it's good to be natty, 100%. Lift natty. Don't use steroids. I'm not a doctor. I'm not a physician. Don't sue me. Just like steroids, anabolic steroids appear to be terrible for you. I don't see many cases where it's great for people. Yeah, you might get jacked. Terrible for your testes. Terrible for your mental health usually. Bad for your cardiovascular health long term. But what would I know? What would I know? Okay. The final post of this podcast. Let me retweet it real quick. Okay. So Dr. James Davies, PhD at J. Davies, Davies, PhD. He said this about 4 days ago. It's about meds. So Dr. Davies said, most therapists are scared to admit it, but SSRIs can undermine the therapeutic process, in parentheses, and often do. By blunting emotions, they can dial down the very signals and experiences therapy depends upon to work, creating a form of dissociation that less enables than disrupts the healing. Okay. So his point, again, taken charitably, is that because SSRIs in particular often have the adverse effect of emotional blunting, because it's stabilizing your baseline serotonin availability, most of the time, most human beings, we have regularly fluctuating neurotransmitter levels depending upon stressor, sensory inputs, diet, all these things. So it's a variable input-output of neurotransmitters. SSRIs and related drugs stabilize how much is there consistently over time and available. So you will have a stable or blunted, sometimes, mood when you take SSRIs, sometimes, in some cases. So he said most therapists are scared to admit it. And I don't know who most therapists are. I don't know. I never know who these people are talking about. Who are they talking about? Who are most therapists? Most therapists are so uneducated, they don't know shit about medications, to be quite honest with you. I've taught psychopharmacology for like 5 years now. And most of the time, the MFTs that I teach are shocked at some of the things that we learn. And then they have a super well-informed, critical thought process about medications where they're not just zombies who believe meds are awesome, and they're not just anti-psychiatry morons who believe meds are the devil. They're reasonable people. I teach people to become reasonable, skeptical, critical, and adaptive and thoughtful people. And it works great. And I trust them to go out there and have educated, thoughtful conversations about meds. So Dr. Davies, who are these people who are scared to admit it? That SSRIs can blunt your mood. It's a well-known thing. So who is scared to admit it? Find them, point them out to me, show them to me on Twitter or whatever. Now, the second part of this is SSRIs, by blunting emotions, can dial down the emotional signals that therapy creates or experiences, which disrupts the healing process. So yes, in some cases, but do we actually know to what degree? No, we have no good peer-reviewed data. And I pushed him on this, and he didn't have anything to come back at me with other than, yes, blunting is common. But like, how does it actually interfere with therapy? We don't know. We need to do more research to figure it out. So stop saying shit that you just can't prove or confirm with data. For the love of all that is holy. And that is it for today. That is as much ranting as I can fathom and stomach right now. Thank you all for being here and joining me on this journey of rambling and criticizing and trying to be reasonable and occasionally even funny and interesting. If you found any of this helpful, if you believe that something I said was valuable in creating a more nuanced consumer, a more informed consumer of therapy services, please like, share, and subscribe. Let's get more people here chatting so that we can have more people talking about reasonable perspectives on psychiatric medications, on types of therapy interventions, on politics and therapy, on what managing countertransference looks like, what's going well with the profession, what's going wrong with the profession. I want to talk about all of it. I want this to be a well-rounded conversation where all opinions are welcome. And I hope today, even though I was very critical, I hope you heard what I'm trying to do, what my intention actually is. I'm trying to protect the consumers from being scared away from things that might be helpful or being convinced by stupid fads. And unfortunately, the people that are good at promoting fads are the ones that have the biggest platforms right now. Some people are decent at being skeptical and reasonable. Scott Barry Kaufman, occasionally Jordan Peterson, occasionally Andrew Huberman, etc. But a lot of the big, pro-psychiatry, anti-psychiatry people are the loudest voices in the room, and they're part of the problem, right? So let's be reasonable together. Let's build this podcast out so we can have more and more people being reasonable together, and we can build a coalition of the reasonable middle that's trying to actually do the right thing. Oh, Phil said, sick and unruly. I did talk about Justin's podcast, listen, or his tweet. Like, literally speaking, psychiatry is not trying to tamp down on the sick and unruly. People who are mentally ill are not unruly. Unruly is a broad umbrella term for behavior I don't like or that's socially unacceptable. Whereas people with mental illnesses have very predictable, reliable patterns of symptoms that aren't merely unruly, like they're out of control, right? So unruly is someone who is voluntarily trying to cause a ruckus, whereas people with mental illnesses are not acting with all of their full psychological capacity. So they're not unruly, so the people who are mentally ill are not unruly. They might act that way, but unruly really implies that you are capable of managing yourself. So I don't see that's true for people who are floridly psychotic or whose PTSD flashbacks are so severe they rage out. That's not unruly. Those are symptoms of mental illness. And I don't blame them for that. Most of those things are reactions and reflexes, not unruly. And we're not trying to medicate away and coping skills away unruly behavior. That's stupid. So, there. You happy, Phil? Is that fair? Is that good enough? I don't know. So anyways, please like, share, and subscribe. We will come back again next Saturday and try and do it again. Maybe even do it better with more people. Thank you all for being here. I really appreciate you being here, commenting, sharing, chatting, saying funny things, making faces. That's all great. I want more of it. Let's do more of it. Let's hang out and have fun. Let's build a community together. That's cool, So again, please like, share, and subscribe. Let's do it again next week. Let's do it better. And as always, I end these podcasts with a dad joke. So without further delay, here we go. Once upon a time, I had a patient. This person had a really severe case of what we call agoraphobia. For those of you who don't know, agoraphobia is a type of phobia. It's a fear disorder, where when you have a phobia, you have this excessive, irrational, not based in reality, fear of something. So agoraphobia is this tragic disorder of being terrified of being outside, alone, helpless, where you can't get help and things like that. So trapped on the subway, trapped in an elevator, trapped in a park somewhere where you can't find help, etc. So it's a phobia. It's a drastic fear of being alone. Anyways, so this patient had agoraphobia. They were shut in their apartment for 10 years So I started doing telehealth therapy with them. And then eventually we did some exposures. We created a fear hierarchy. And we started doing mild exposures of like stepping outside the door and things like that. And it was actually going well to the point that they started to come in for therapy. So it was going super well. By the time we got to the last exposure on the fear hierarchy, the last exposure for this person with agoraphobia was to go to a botanical garden when no one's around and get lost, basically. So the exposure was to go to a botanical garden and get lost, essentially. And the guy did it. And he went to the botanical garden. He came back the next week for a session. He looked at me and said, Dr. Lockwood, it went so well. I said, that's amazing. Tell me about it. And so when the patient came back and told me about it, he said, it was amazing. Like, I never thought I was capable of being basically by myself in this giant maze that's the botanical garden. And he told me more about it. And, he told me about all the plants and the trees, and there were some bugs and bees and stuff like that. And there were some cool flowers he'd never seen before in his life. And, there's some ordinary flowers, daisies and roses, and some cool flowers. He'd never seen purple and all these cool colors. And he looked at me and he said, you know what? I never thought this would happen, but I feel like I'm actually okay now. I think we can be done. He said, what do you think? And I said, you know what? Sometimes you kind of just have to stop and smell the roses, and then everything is okay. All right. Have a good night, everyone. Take good care of yourselves. Have a good Saturday. Take good care of yourselves. Eat good food. Have good sex. Have fun. Good friends, good family, good work. I will see you next week. Be good to yourselves. Talk soon.